And as soon as you cool it below the TG or below glass transition temperature, it's becoming more difficult, the chains to move, it's becoming more restrictive, and that's glass transition temperature of a polymer. And that is representing amorphous part. So you can think of that cooked noodle or spaghetti. You are cooling it, and at a certain temperature, when you go below TG, that glassy noodle, easily movable noodle, is becoming more restrictive in its movement. That's glass transition. Below TG, the material is amorphous, solid, or like a glass, glassy. Okay. I'm going to read it, but basically what I just said, as the polymer system is cooled, rotation around single bonds become hindered. As the temperature drops, the rate of rotation around the main chain in a polymer becomes slower and slower, and chain gets stiffer and stiffer just below TG. Eventually, at a low enough temperature, single bond rotation ceases, random coils become frozen. This is called glassy state, and the temperature at where single bond rotation ceases is called glass transition temperature. Okay, or you can think little bit other way. If a polymer is above its glass transition temperature, so for example, you have a little bit rigid polymer, you start heating it little bit. As soon as you go above its glass transition temperature, it starts becoming more flexible. Okay, material below TG is glassy, hard, stiff, and brittle below TG. Okay, due to Brownian motion in a liquid or melt state, polymers have enough thermal energy segments to move randomly. Glass transition, as T decreases to a particular point, all long range segmental motion cease, polymers solidify, becomes hard and glassy without crystallization. All polymers will experience a glass transition temperature. Why? Why all polymers will have a glass transition temperature? Because they will always have some amorphous component. And glass transition temperature is related or correlated to the amorphous part, and since all the polymers have some amorphous part, 20%, 10%, 30%, there will always be a glass transition temperature. So material is glassy and hard in that picture image. Then you go above TG, now it becomes soft and rubbery. And we have not talked yet, then if you keep heating it, now you are making that crystalline part to dissolve. So Tm is always greater than Tg, because Tm is corresponding to that uncooked noodle, and that's more stiffer. You need higher temperature for that uncooked noodle to melt. That's why it's melting temperature. We won't watch the video. You will have the slides, you can watch it. It's a 5-second video. Basically the video is like it's a gum and it's very brittle, you know. So they show that you just heat the gum in microwave little bit, and now it becomes very stretchy and very rubbery. Because it was below TG, it was brittle and glassy. You heated it little bit, it crossed that TG temperature, and now it became very rubbery and glassy, very flexible. Above TG polymers are rubbery, whereas below TG they are glassy. Rubbery behavior arises from the polymer's ability to change its conformation at higher temperature. Glassy behavior arises from the polymer's lack of ability to change its conformation. The motion ceases. Lot of hard plastics that you see, they are above TG or below TG? below Tg, right? But if you are seeing a softer material, it's above Tg. It's at a higher temperature than Tg, it's flexible, that's why it's softer. So hard plastics are above Tg, below Tg, sorry, and rubbery materials, softer materials, polyisoprene, which is a rubber, that's above Tg, that's why it's in a rubbery or softer form than a very hard solid form. Okay, so now I want you guys to take 5 minutes to just write it in your notebook. Don't discuss. What will happen if you have a chain length? If it's a longer chain, will Tg go up or Tg will go down? If chain becomes more flexible, Tg will go up or Tg will go down? If there are more side groups, Tg will go up or Tg will go down? If you have branching or cross-linking, Tg will be higher or lower? So I have a polymer, I add some branches to it, now the new Tg will be more or less than the previous Tg. If you have a plasticizer, anybody knows what's a plasticizer? Plastic making compound, that's correct. So sometimes some polymers, they are not easy to work with without a plasticizer. Plasticizer adds, it softens the polymer. Okay, so PVC is a good example, polyvinyl chloride. Without a plasticizer, you won't be able to work with it. So you always have some plasticizer added to it to make it more flexible. So plasticizer is adding little bit flexibility to the polymer. You can think like that. So take 5 minutes and try to answer these questions. If chain length increases, Tg will go up or down. Flexibility increases, Tg will go up or down. Trust me, this Tg low, high, it confuses me also a lot, okay? But it's not difficult if you'll think about it. Okay, maybe you can discuss with your person next to you. So two people can discuss and then you have to come up with the answer. I'll ask a random group to answer. Okay, which group will answer chain length? If chain length increases, Tg will go up or down? Maybe that group. Tg will go up. Okay. If chain length increasing, Tg will go up. How many of you agree with that? And how many of you think Tg will go down? Okay, so it will go up. Can you explain why?
As you said, above Tg our material is rubbery, right? So if chain length is increasing, so that is more depending to the Tg, it will be increasing.
So if chain length is increasing, it's becoming more difficult. You need to provide more heat for it to become softer, right? So temperature is going up, Tg is going up. Okay, if chain flexibility is increasing, Tg will go up or down? Down. Okay, and can you explain why? Yes, so see, the chain is more flexible. You don't need it, it's not so difficult for you to make it move. It's already becoming flexible. Okay, more side groups, Tg will go up or down? Up. Okay, so I'm not explaining now, but if somebody has doubts we can talk later. But yes, same, if it has more bulky groups, it's more difficult to move it, right? Let's forget branching. Cross-linking. If you have more cross-linking, Tg will go up or down? Up. It's more difficult, it's cross-linked now. Presence of plasticizer. TG will go down because adding plasticizer basically means you are making the chain flexible. So if you are adding more plasticizer, it's more flexible. If it's more flexible, TG is down, right? Okay, who will answer branching?
Branching, more bonds will form like hydrogen bond or bond over bond. So more energy will require to break that.
So TG will go up. Okay. Anybody says TG will go down? See, I've skipped that, so it must be a tricky one. So maybe it's not the answer that you think it is. Down, why? Yes, so packing, more free volume is there. So actually the answer is it can be up or it can be down depending on where the branching is, and is it more free volume or is it more issue like she said. So it can be either way actually. Okay, but very good. Usually this is the confusing part, but you guys answered it, so good job. Okay, but if you have questions, doubts, it's not clear, I'll be here after 4 o'clock. We can talk after the class also. Melting temperature. As temperature increases to a particular point, the crystal structure of polymer starts to melt. This temperature, owing to melting of the crystalline phase, is called melting temperature. Okay, so I said earlier, crystalline is Tm and amorphous is Tg. So Tg was when the chains are becoming more flexible or more glassy, but when you keep increasing the temperature, now your uncooked noodles or crystals of the polymer starts to melt, and that is called melt temperature of the polymer or Tm of the polymer, and it's always higher than Tg. Tg is not same as melting. That's different thing. Melting is a transition which occurs in crystalline polymers. Melting happens when polymer chains fall out of their crystal structure and become disordered liquid. Amorphous portion undergoes Tg only, crystalline portion undergoes Tm only. Crystalline polymers will have some amorphous portion. This amorphous portion usually is 40 to 70% of the polymer, remaining 30 to 60% is crystalline. This is why the same sample of a polymer can have both a Tg and a Tm. And here again are some examples. DSC, DMA, they are the instruments used to calculate Tg and Tm of a polymer. But you can see here how Tg is much lower than Tm mostly. Always Tg is lower than Tm. To give you an idea, that last example, let's say rubber, Tg is minus 70, but we are using it at room temperature, right? So that's why it's rubber, because you are using it above its Tg. If you go below Tg or below minus 70, now it won't be rubbery anymore, right? Now, we little bit talked about it earlier, thermoplastics and thermosets. Thermoplastic is you can melt it, soften it, dissolve it and reform it in a new shape. Polypropylene, PTFE. Thermosets, they are set, they are cross-linked, you cannot melt them, soften them, and rubber is a good example. Okay, now we have a numerical problem. Molecular weight of polymers. So like we talked earlier, when we make a polymer, they have different chain lengths. They can be very short, very long. molecular weight of a polymer, there are two types to calculate it. One is called number average molecular weight, one is called weight average molecular weight. Okay, weight average molecular weight divided by number average molecular weight is polydispersity, and if polydispersity is 1, then chains have same length. Okay, I'll show you the formula. It sounds confusing, it is little confusing. I'll show you the formula and then we will do an example problem. Number average molecular weight, weight average molecular weight. Write this formula because we are going to do a numerical problem. Like first column, number of molecules. So one molecule, mass of each molecule is 800,000. So our formula for number average molecular weight is summation of NI-MI divided by total NI, right? So total of these molecules, total, that is the denominator, summation NI. And summation NI-MI is one molecule is 800,000, so 1 multiplied by 800 is N1M1. 3 molecules, 750, 3 multiplied by 750K, that is N2M2, N3M3, N4M4. Summation of that 50,000 is your numerator. Okay, just look at it for 1 minute, you will get it.
Sir, how come the mass of each molecule is decreasing when the number of molecules?
Oh, they have just written it in that way. So see, it's like a bell curve. There are some molecules that are very high weight. See, mostly it's like a bell curve. So some are very high weight. When you were doing the synthesis, some became very high weight, some became very low weight. Most of them were in the middle. So it's showing a little bit of that. Now weight average molecular weight is, just look at the formula again. Wi is NI-MI divided by summation NI-MI. Okay, and then molecular weight is summation of Wi-MI. So look at it, we will do a numerical, it will become more clear when we'll do it. So if you think, let's remember this, Wx is NX-MX divided by summation NX-MX, right? So if you put another column here with Wi, it will be, we wrote X instead of I, but it's NI-MI divided by summation of NI-MI. So 800,000 divided by 50 million, 2.2 million divided by 50 million, that is basically this. Okay. And then when you calculate weight average, you will multiply that Wi column with Mi. So 800,000 divided by 50 million multiplied by 800,000, that will become W1 M1, W2 M2, W3 M3, and summation of all those will be weight average molecular weight. Another thing, weight average molecular weight will always be greater than equal to number average molecular weight. Weight average molecular weight is never going to be lower than number average molecular weight. Okay, so write this formula because next slide will be a numerical problem that you will do it. Very simple. It won't have so many numbers. I see some people's eyes are closing after a nice lunch, so stay awake because I'll randomly ask somebody to answer this next question, okay? Did you guys write number average molecular weight formula? Okay. So write for weight average molecular weight. So basically you need to write this and this. If you know this and you know this, you'll be fine. And you know there is an exam on the last day, I think. We need to take an exam. Whoever. We can talk about it later today. We can talk about it actually. So I think I was told people who will pass the exam, only they'll get a certificate. So you have to pass the exam. Okay. Okay, ready? Okay, so you have to calculate weight average molecular weight, number average molecular weight, and polydispersity index. But look, it's so easy if you think. Summation NI-MI divided by summation NI. Yes.
It's the total NI-MI.
So summation NI-MI means N1-M1 plus N2-M2 plus N3-M3. Yes. Might be. I don't remember, but okay. So number average, I think everybody got, right? How much is it?
26,000.
26,000, right? If somebody didn't get it, it's just 5 multiplied by 10,000. So 50,000, 90,000, 120,000. Total of that becomes 50 plus 90 plus 120, 260,000 divided by 5 plus 3 plus 2, that's 10, so 26,000. Okay, so one thing we know, that weight average molecular weight cannot be lower than 26,000. So if anybody got lower than 26,000, that's wrong. So that's one surety. Okay. And we know to calculate weight average molecular weight, we already have NI-MI. You will draw another column, NI-MI, right? And then WI is NI-MI divided by summation of NI-MI. Summation of NI-MI was $260,000, right? Now NI-MI was 50,000 divided by 260,000, 90,000 divided by 260,000, 120,000 divided by 260,000, and the last column is 50,000 divided by 260,000 multiplied by MI, that is that. So the answer is, even I don't know. And what is the polydispersity index?
1.54.
Okay, so it cannot be less than 1. Okay.
Sir, can you repeat that molecular weight one?
MW. How did we get
Yes, sir.
this one? Oh, so this is summation of W1, WIMI means W1M1 plus W2M2 plus W3M3, right? W1 you calculated by that formula.
That exactly, master.
To repeat.
Yes, sir. The way you were giving the facts.
Oh, so 50,000. So NI-MI is this one.
Yeah,
Divided by 260,000, because it's N1M1 divided by summation of this whole thing, and then 90,000 divided by 260,000, 120,000 divided by 260,000, that's that column, and then multiply 10,000 with 0.192, 30,000 with that, 60,000 with 0.461, and summation of that last column is the weight average molecular weight. Okay. Now we have a video to watch, but let's go a little bit longer I try to put video in between so you guys don't sleep and it's something interesting. But since we started only 30-40 minutes ago, I can go a little longer because you are still awake, and then we can play the video. Okay. So selecting plastic materials for medical devices. Hospital acquired infections is a huge issue. We will talk about infections in the next few classes, but just to give you an idea, 1.7 million hospital acquired infections, 99,000 deaths per year. This is just in US, right? So we want materials, we want polymers that can prevent infection. That's anti-fouling. Polymers, medical devices, proteins come and stick to the surface. Bacteria grows on that surface. Blood contacts that surface and clots on that surface. We want to prevent all that. We want polymers that are biocompatible. We want polymers that are easy to process, easy to work with. While synthesizing the polymers, we don't want any toxic byproducts, or we don't want chemicals to be used that are very expensive, because that will increase the cost of the medical devices, right? And then there is emergence of bioabsorbable polymers because of pollution concerns also, right? If slowly material can degrade over time, that's great. Without hurting the cost, without having any toxicity issues, so these are all the challenges. Now, factors that influence properties of polymers, of course, chemical composition. How many monomers are there, because their weight average molecular weight change, number average molecular weight will change. How many pendant groups are there, how much hydrogen bonding is there, what is the percentage crystallinity of a polymer? Do we want a more amorphous polymer, or do you want more semi-crystalline polymer? Do you want a thermoplastic, or do you want a thermosetting polymer? Molecular weight of polymer, because a higher molecular weight polymer has different properties than a low molecular weight polymer, right? Compared to metals and ceramics, polymers have much lower strength, but they can deform to a greater extent before failure. If you remember that stress strain diagram of metals versus ceramics versus polymers, you can see you can apply stress and there can be more strain. Some examples for cardiovascular implants: polyethylene, polyester, silicon rubber can be used. For orthopedic, you can use for the cup of that hip implant. Drug release, we have just written PLGA for example, because it's a completely degradable polymer. It can just release everything. For tissue engineering, we can use scaffolds that can slowly degrade while tissue is taking its place, right? Now, of course, whenever you are deciding what application, what are you looking for making, you need to consider what are the characteristics of the polymer. So polyethylene, low density, good toughness, good wear resistance, can be used for tubings for drains and catheters, artificial hips and other prosthetic hip joints. Polypropylene, high rigidity, good chemical resistance, good tensile properties, excellent cracking resistance, so can be used for sutures and hernia meshes. Maybe we'll talk later about it. Hernia meshes, infection is a huge problem for hernia meshes. And modifying hernia meshes is a very difficult task actually to make it antimicrobial. PTFE or polytetrafluoroethylene, very high melting temperature, difficult to process, very hydrophobic, excellent lubricity and low friction, used for vascular grafts. You know, earlier we were talking that how porosity, So this type of vascular graft material, you want cells to grow in them so that it just starts becoming a part of their blood vessel. So if somebody's blood vessel is damaged, you can put a vascular graft to bypass that area. And I will have like few slides only on vascular grafts later, not today, but in one of the talks. Polyvinyl chloride, it's hard and brittle. If plasticizers are added, we talked about plasticizer, it makes it a little bit more flexible. Used for tubings, endotracheal tubes, catheters. PDMS or silicon rubber, or that polymer that has that inorganic backbone, it's a versatile polymer, poor mechanical properties. You know, when we make films of PDMS material, you can actually just tear it with your hand also. It's sometimes so poor properties, mechanical properties, but excellent flexibility and very stable, high oxygen permeability. So for finger joints, heart valves, breast implants, catheter and drainage tubing, urinary catheters are made up of silicon rubber, or urinary catheters are also called Foley catheters. We will talk about it later. Membrane oxygenators, some examples of that polymer. But you know, whatever I have talked so far, all these things, infection is still a problem, or clotting is a problem, or body can still reject it. So the beauty of polymers is, yes, you can make these materials, but then you can put drugs or antibiotics or some antimicrobial agents in the polymers so that they can slowly release and fight that infection and clotting or whatever problems are having. Polyethylene terephthalate, it's a polyester, contains aromatic rings, very high tensile strength, used for ligament reconstruction, hernia repairs, it can also be used. Nylon 6,6, have you guys heard of nylon 6,6?
Yes, sir.
When? Today did we talk about nylon 6,6? We did?
In condensation reaction.
Condensation reaction, right? Adipic acid reaction with hexamethylene diamine to give nylon 6,6, and what's the byproduct?
Water.
Water, right? So it can be used for surgical sutures. What is another common material used for sutures?
PP.
Okay, what else? Silk, right? I think you must have heard silk sutures, right? Another polyhema, it's like a swollen hydrogel. So what is a hydrogel? Have you guys heard about hydrogel?
Yesterday we talked about.
We did? I don't remember actually. Okay, maybe we did, but I don't remember. So what is hydrogel? If we talked, you'd know then.
With relevant to that cataract on we were talking.
Yeah. So hydrogel, like you know, name suggests hydrogel, right? It can absorb lot of water. It can swell with lot of water. So very hydrophilic, it loves water. Transparent, amorphous, that's why good material for soft contact lenses. Okay. Biodegradable polymers, polylactic acid, polyglycolic acid, or polylactic co-glycolic acid. It has lactic acid and glycolic acid. Polycaprolactone. Now, the beauty of this PLGA, we call polylactic co-glycolic acid PLGA also. This is PLA, that is PGA. You can design these polymers to degrade very fast or degrade very slow. So they can degrade in a week or two, and they can degrade in 2 years. So depending on your application, we will talk about PLGA again, so keep it in mind when I talk little bit about my research, maybe later this week or early next week. So this PLGA material, it can degrade so fast or it can degrade very slow. So if you want, let's say you are making a suture and you want it to degrade in 6 months, you can design that material. If you want, for some reason, you want some very fast drug delivery to happen in a week or two, you can design that PLGA material. Eventually disappears and the byproducts are not toxic. Byproducts are glycolic acid or lactic acid and they can easily be excreted from the body. It's FDA approved also for drug delivery applications. Various degradation rates, sutures, drug delivery, vascular graft stents, tissue engineering, okay. Okay, some examples. We will talk in detail about some of these applications later, but I just thought I'll just give you some examples. Foley catheters or urinary catheters. Naturally sourced latex rubber can cause allergy. Heavy metal, still 30% of the BARD sales are from these Foley catheters. Infection is a huge problem with Foley catheters. You can imagine a urinary catheter, there can be a huge problem with infection. So you know a fact, they say, what do you think if somebody has a urinary catheter for a week, what are the chances of infection? Anybody else? So they say for a urinary catheter 1 week, chances of infection is 25%. And for a month, it's 100%. So you can imagine that you need to change the catheter so frequently because of infection and it can be so painful. I have a friend who told me his mom was older, in 80s or something, and for some reason she had urinary catheters, and she said every month she will call and say, you know, my urinary catheter is infected again. So you know, you need to get antibiotic doses and change the catheter, like so much pain. And see, the problem is a patient is going to a hospital to get treated for something else, and that something else is bothering them, but maybe this urinary catheter infection is now a bigger problem. People who are immune compromised, infections are a huge problem for them. If infections become worse, they can get sepsis. Now it becomes even more deadly. Also, I don't want to forget, maybe this is not the right place to mention it, but I don't want to forget it. Different applications, different bacteria count is considered infection. So for bloodstream, maybe 10 to the power 3 CFU per ml is considered infection, and maybe for urinary catheter I might be a little bit off. 10 to the power 4 or 10 to the power 5 CFU per ml is considered infection. So huge problem, you know. US market around approximately $10 per unit for a urinary catheter. It might be a little bit less, little bit more, just to give you an idea. This is how urinary catheter looks. And again, when we'll talk about urinary catheters, I can show you a video also. But to give you an idea, that balloon and this balloon port. So through the balloon, so they insert the catheter, and then through the balloon port, they inject saline that goes in that balloon and inflates it, so the catheter does not come out from the bladder. It just stays there. So I mean, technology is so cool, but at the same time, you can imagine how painful the whole thing can be. And if it gets infected, it's a problem. On the other side of the catheter, you have a bag that collects the urine. So just, I mean, sad, but at least there are things to help. In Yes, yes.
So,
Oh, sorry.
so why do we need to keep it for one more long week? Can't we change it more frequently?
Oh, yes, yes, yes. So you can change it, but remember, changing the urinary catheter can be a painful process also.
The process itself is same.
Yes. And I might be wrong, but I have heard, so in US, infection of the catheters or hospital acquired infections, they bring the rating of the hospital down. So more and more infections that happen during a patient stay, it hurts the hospital rating. And I have also heard that if somebody gets a hospital acquired infection, insurance companies have problem with the hospital paying for it because they think it's hospital's negligence. So lot of times actually hospitals change urinary catheter very frequently just to avoid that infection from happening. Now, I'm not an MD, so I don't know what are the detrimental effects of doing that, but I feel taking and putting a new catheter again and again, it cannot be a good thing for a patient. But if it can prevent infection from happening, then it's worth it maybe. That's why we will talk, my group and so many other people are working on antimicrobial urinary catheters. If a 1 week can be prolonged to 2 weeks or 3 weeks, that's great. And imagine patients who are paralyzed waist down, they have permanent urinary catheters. Like permanent means they need to have urinary catheters all the time. So, okay, somebody goes to a hospital for a week, get a urinary catheter, gets infected. It's painful, but you can understand it's 1 week of misery, right? But if somebody has a urinary catheter for a very long time and periodically it keeps getting infected, that can be very difficult. So intravascular catheters, you are putting it in bloodstream, they are much stronger material, higher margins, more expensive, $1,000 a tray because it comes as different parts. Again, infection can be a problem and clotting can be a problem now because it's going in the bloodstream. Vascular grafts, you want a porous material. PTFE is a very common vascular graft material. Gotex is a company that makes PTFE graft. It has a big market share. You want porous because you want endothelialization to happen. You want endothelial cells to grow around that graft material so that the graft becomes like a part of the blood vessel kind of. Okay, because if these endothelial cells grow on the graft material, now chances of clotting and infection reduces because it's just acting like a blood vessel now over time. They are hydrophobic materials, membrane oxygenators to oxygenate blood, porous material with high gas permeability, large surface area because you want lot of oxygenation to happen when the blood is flowing through that oxygenator, right? Polysulfone, polymethylpentene are commonly used fibers for these membrane oxygenators. But the issue is in an oxygenator, blood is touching these oxygenators, right? So gas is flowing on one side and blood is flowing on one side. Okay, and blood is clotting also on these. So to prevent that, we will talk about this later also, but to prevent that, you heavily heparinize the patient. Blood has lot of heparin in it because heparin prevents clotting from happen. Okay, it keeps the blood liquid and flowing, but some people are allergic to heparin and it can cause thrombocytopenia. So it's not always desirable. Also, if somebody is on lot of heparin and they get hurt, guess what? They will bleed now because their blood is not clotting. You have given them lot of heparin. So all this can happen, but a challenge with this polymethylpentene is we are working with this material too. It's very difficult to modify this material. Coating these oxygenators is a huge problem, because if you coat it to prevent clotting, first of all, modifying this polypentene is so difficult. Second, okay, even if you can do it, will oxygen exchange happen now still properly? Or the efficiency of oxygen exchange will go really down. Now that will be a challenge.
So can't be coated with the same proteins that alveoli are coated?
So, okay, I'm sure first of all, if you just do Google search, Google Scholar, somebody must have tried. Whatever idea you can think of, people would have tried. I'm sure there must be challenges. So for example, if you coat with certain things, but maybe you cannot sterilize it, and you have to sterilize these things. And I'm not sure that's the problem. I'm just telling you one problem can be sterilization can be an issue. Cost can be an issue. Okay, you coat it with whatever protein, but now maybe oxygen exchange won't happen. So we think of solutions, but then you start working on it. You will realize in your PhD soon, you are junior, even the simplest of the projects that you think, oh, 1 year I can get this paper published. 3 years later you are still struggling with that project, and it sounded so easy. So all the work that I'm showing, so far I have not shown anything our work, but other scientists who have done this great work, it took years and years. Like I'm just showing it on one slide. Hey, somebody made this material. But imagine how many years it took somebody to even make that material, and even then we have limitations and issues with it. Just an example of an oxygenator. This is like an oxygenator. Blood goes through it, but then there are like so many pack of these fibers there in which there is oxygen, and you're trying to get oxygen gas transfer happening, so to oxygenate the blood. Okay, case study. Now I want you guys to take 5 minutes to think about it. Maybe the first one will be more difficult. Think about it for 2-3 minutes. I don't expect you guys to answer this one, but I'll show you. But then there'll be 2 more case studies that you can try to do. Hip surgery to alleviate the pain and stiffness of arthritis or to repair the joint. Artificial hip has 2 pieces, femoral ball and stem, and the cup. What do you think properties are needed for this material, and what polymeric biomaterial is used? I don't expect you to be able to tell what polymeric biomaterial to be used, that's fine, but what properties needed, and this is just a case study. I think this study is from that big book I showed you. One of the things that people have tried, but with science, so many new materials are coming. But what do you think are the properties?
It should be strong enough to hold the
Yes.
bullets, needs to be bullets.
Yeah, sure, for the cells to grow. And I'll just show it to you. Low friction and resistance to wear, right? Now, this is an interesting thing, the polymeric biomaterial. So, British orthopedic surgeon Sir John Charnley used PTFE, a very low friction material, for the cup. He used stainless steel for the ball and stem. Okay, but 2 problems happened. One, PTFE did not have necessary wear resistance, so it got worn out fast, and small pieces of PTFE eroded from the surface of the cup, causing inflammation in the surrounding tissue. Second, this stem that goes inside the bone, like he was drilling in the surgery to put this stem in the bone, it loosened over time. No, that's a problem too. So then his friend helped him. So very high molecular weight polyethylene does not produce this wear debris that this material did, PTFE. So he used that high molecular weight polyethylene, and his friend said that for dental implants they use this cement, PMMA dental cement. Why don't you put this cement along with the stem to hold it? So that with high molecular weight polyethylene, mechanical strength improved, and with the cement it didn't get loosened. Now you guys have to do it. Think yourself, take 3-4 minutes and try to solve this problem. What do you think? So need, I have already mentioned. We need soft contact lenses because there is not enough oxygen transport to cornea, But what do you think are the properties needed for this material? And what is a good polymeric biomaterial used? Okay, so glass contact lenses can be very uncomfortable. You cannot wear for a long time. What do you think are important properties we need to make soft contact lenses?
First, oxygen transport to
Oxygen transport should be good, yes.
It should be transparent.
It should be transparent.
It should stay sterile. It should not get infected easily.
Sure, yeah. I mean,
Flexible, resistant, sharpening.
Biocompatible.
perfect. Okay, so yes, it should be flexible and it should be water loving, because if it's very hydrophobic, that will be very irritating to the eye, right? Okay, what is a polymeric biomaterial used? We talked about that hydrogel today, right? Polyhema, we talked about it, right? So polyhema is a glassy in dry state, so easy to fabricate. Hydroxyl groups result in hydrophilic polymer. Adsorbed polymer plasticizers resulting in softness and less eye irritation. But polyhema is not sometimes capable of providing necessary oxygen. So often it can be co-polymerized with other monomers such as silicone, which has better oxygen transport. So it helps, and making thinner lenses, which is again desirable. Okay. Next one. Okay, I won't go to the next slide. I'll just ask you, you can do it. Resorbable sutures. 1, why do we need it? Or biodegradable sutures. 1, why do we need it? 2, what are the properties? And 3, what is a polymeric biomaterial used?
So that we can reduce our
Right. So that everybody gets little time to think. Because my worry is sometimes when some people answer, others sleep. So this way everybody is writing and focused. Yeah. And also if you have an internal injury, they closed it and then they need to redo the surgery to go back and remove it. So that's not practical, right? So that's easy question. Now, what are the properties?
should be like equal with should match inside the body, degrade inside the body, just biocompatible.
Biocompatible, yes. And what is like it's already degradable. So what are you trying to say?
Rate of degradation. Yeah, exactly.
Rate of degradation and regeneration should match. Okay. What else?
So it should aid in wound healing. It should have certain antimicrobial properties.
I mean, if that can do, that's like a plus. That's icing on the cake. But if basic, what else do we need?
Strength to hold the wound.
Yes, so that's a very important property because it should be strong enough that it keeps the wound closed, right? And you kind of said that the byproducts should be non-toxic. Whatever it's breaking down into should be not toxic to the body, right? Okay, what is a common material? So let me give you a little bit background. I worked for 4 years with Dr. Bartlett. He's a renowned surgeon. Now he's in his late 80s. Just an amazing person. He was like a great mentor. He changed my life, so I'm always thankful to him for whatever he did for me. He's also known as father of ECMO, or extra membrane oxygenator, extracorporeal membrane oxygenator, ECMO. Also now known as, people have changed the name, ECLS, extracorporeal life support. So he has actually saved people's life, babies' lives who are born premature, lungs are not developed, how to keep them alive using this ECMO machine so that the lungs can develop. So very, very famous guy in the University of Michigan. He was like God. On the buses, his pictures used to be there. So very, very nice, down-to-earth person. So, and such a passionate researcher. He travels, like when I was there 10 years ago, he used to travel a lot because he was so famous. But he will come back, no jet lag, and he's in his office working. Weekends, he's in his office working. Just looking at him, and that time he was in his mid-70s, looking at him and his passion to work will make you feel like if you are not working, that's very shameful. You should be working hard. So just very inspiring person. And this is his TED Talk at University of Michigan. So I'm sure you guys will enjoy it. So this video that we have, you guys can watch it yourself online. Here is the YouTube link. I think only 4 minutes of the video was left because they cannot show it online. Okay, so we can discuss your questions now. What are your questions from the class today? Yes.
Shed some light that you told us that
PLGA.
PLGA had a different rate of degradation.
Yes.
Yeah. So what makes it to have
A different rate
of degradation?
Good question. So PLGA is a copolymer of lactic acid and glycolic acid, So you can change the ratio of lactic and glycolic acid. So it can be 20-80 or 50-50 or 40-70, and that will change the rate of degradation for PLGA. And since the video could not be shown, we can a little bit talk about this also, because ECMO is a medical device. So people who couldn't watch it, first of all, they can watch it here. I highly recommend you guys to finish it also. So Dr. Bartlett, his lab was working on a lot of things when I left 10 years, 12 years ago. So one is he invented or worked on ECMO, improved ECMO. So babies who are born premature, they are put on ECMO so that their lungs can develop. Second, artificial placenta, which is again babies who are born premature. He used lamb model to sheep, baby sheep model, to perfuse the baby sheep with the liquid so that they can, because if a baby is born too premature, it's sometimes very difficult to save the baby, or the baby will be permanently disabled. So that's one way work he was doing. And then another work is that organs, lot of times when a patient dies, organ has certain hours that it can be donated. So some organs are 4 to 6 hours, some can be 8 hours or something, but a very, very short period of time. So one research that they were doing was how to keep the organs alive for longer period of time. So see, that's now different type of research. It's not biomaterials, but, and his idea is again coming from ECMO, extracorporeal, but now he wanted to figure out what's the solution they can perfuse that the organ with, so that the organ can stay alive. So if it's a kidney, can you flow certain liquid through it with whatever components in it, so that the kidney, instead of dying in 6 hours, it can survive 1 week, so that you can actually take it to the patient? Because what if the patient is in India and somebody is donating in US? So can you bring that kidney to the patient now? Or what if today there is nobody available who we can donate this kidney to, but if you can store it in a storehouse of organs, a month later or 4 months later, if there is a match, you can now donate the kidney to that person. So that's another research area they were working on. I forgot, but you guys didn't remind me, you were going to send me your assignment today. Okay, so maybe you can send the assignment now if you want, if you have it ready. You can email it to handahitesh@gmail.com. So my last name, my first name @gmail.com. That way I'll remember who you are. Okay, so questions for whatever we discussed today. We discussed a lot of things: metals, ceramics, polymers, TG, glass transition temperature, melt temperature, crystalline polymers, semi-crystalline, amorphous, molecular weight, lot of applications of polymers, right? Sutures, Foley catheters, vascular catheters, hydrogel for, like, let's say lens type application, case studies. Questions?
So how we can deliver drug across the blood-brain barrier apart from polyethylene glycol, that is most common?
So honestly, I'm not the expert to even comment on that. I don't work in that field, yeah, but it's a challenge, yes, I know.
So what are the properties of the material or whatever we have learned should be to cross the blood-brain barrier?
I feel that should be more, instead of more of the material properties, it should be the property of the drug that you are giving through the.
So but the drug carrier needs to have certain
that
properties.
yes. So I mean, if it's like a polymer, can it survive that, or can it retain the drug for long enough time? Can it pass through the barrier? But less my area, honestly, so not a good person to comment on it. Yes. And we will talk about drug delivery through the polymers later. That will be a big part we will talk. I wanted to talk more about, so my plan is to talk more about materials, polymers, ceramics, metals. Then next class we will talk about problems. So for example, fouling of surfaces, so protein adsorption, infection of surfaces, clotting of surfaces, and then some potential solutions that we can provide.
So, as we were talking about implants, and we are talking about that how to prevent infections happening because of it. So, but now that there's so much advancement in technology that we're talking about chips inserting, and we are using nanobots and everything. So need these kind of coverings from like polymers or like what kind of biomaterial is used for them, so that will they also in will help in creating infection or what, or how, what are the side effects of them, or like how are they different from implants and
Sure,
how are they similar to implants?
sure. So, depending on where the implant is, different bacteria can colonize the surface, and there are different higher or lower chances of infection. So, for example, urinary catheter, very high chances of infection. Endotracheal tubes, very high chances of infection. But some other implants, for example, if somebody has a bone implant, maybe the chances of infection is much lower. So I won't say that infection in these type of nano carriers is, but probably it's not as high as a urinary catheter or a vascular catheter or endotracheal tubes. Especially if you have an implant, if there is a cut and you have implanted a device through that cut, now the chances of infection is high, because that interface where the implant is going in the body, that interface chances of infection can be very high. But if you implanted somebody, closed it, now chances of infection are low. So we will talk about it later when we talk about urinary catheter, but earlier urinary catheters were, so now there is a bag outside the urinary catheter that collects the urine, okay? But earlier they didn't have this bag at the end. It was like open urinary catheter. And actually she was right when she said chances of infection is 100% in 7 days. When they didn't used to have a bag, the infection used to be maybe even 100% in 4 days, or very fast, because you had an open system. Now, at least by putting the bag at the end of the urinary catheter, you are little bit preventing and prolonging that infection to happen. So again, depending on the situation, wound dressing, chances of infections can be high. So it depends on the application, and then it also depends on the cost. That, okay, first of all, is a problem really big? And yes, if the answer is yes, the problem is really big, then you talk about, okay, can we make it antimicrobial and how much cost it will add to the device. But if the chances of infection is 1 in 1,000, probably nobody would want to fabricate or manufacture or sell antimicrobial in that, because they feel the problem is not that big. I recently was talking with somebody. They sold their company, I won't say the name or anything, but they sold their company and they were working with some ankle implant. So I told him, because my lab works on antimicrobial, making devices antimicrobial. So I told them, hey, maybe we can work and make your ankle implant antimicrobial. But he said the chances of infection is less than 1 in 1,000. So the company will not even entertain the idea of making that antimicrobial implant because the chances of infection is so low. So why to increase the cost by $20 or $50 or increase the complexity of manufacturing it when the problem is even not that big? So it depends on the application, if infection is a huge problem or not, and then how much cost it's going to add. So it's like a balance.
Several cases of hairline thin fractures, which are very common, but mostly people assume that it's a ligament tear or something. So, sir, in those cases, could there be a biodegradable implant? Because initially you need that internal support, but over the years, I mean, maybe after a decade, there is so much of muscle development, tissue mass development upon the implant that now it's more painful because there no because it is a very mobile part, like
Yeah.
for example the ankle or the pelvis,
Yeah.
and you have to walk also, but if you want to get that implant removed, it's just like the sutures, it's more painful, it can lead to infection, there could be a loss of mechanical support. So
Yeah.
is there any work related to this?
I don't know, honestly, but I do agree. I have heard that if there is a fracture, even if you feel it's not a big fracture, you should get it checked. Because if bones fuse in a wrong way, now it can be a bigger issue,
Yes.
right? So if there is something temporary, I don't know. And maybe there is also. Honestly, I have not searched in that field much.
You just insert screws in the case of
Yes,
hair to
yeah.
bone fracture.
But then are they biodegradable?
No, sir,
They are not,
That's
right?
the
See, yes. So, but maybe the reason is they are not because finding that strength is difficult, or that match of fixing it with the degradation can be challenging, or I'm just guessing, the cost can be an issue. So maybe that's why they are just going with the traditional method of doing
But
it.
that traditional method is also causing a lot of pain after a decade.
And trust me, there might be groups working on it, right? If you and I are thinking about it, others are definitely thinking about it, and they might be developing. But like in yesterday we talked how bringing anything to market can be so challenging. Maybe people are working on it, and maybe the companies that are selling those screws,
are not letting that.
are they ready to explore this new technology, right? Because they have to go to clinical trials, get FDA approval. Is it worth for them to go through all that processing? So first, is there a good material to do it? If yes, is it worth it expense wise? If yes, is any company ready to go through all that clinical trials and FDA approval? And if the answer is yes, 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 then maybe it's coming soon.
So one more question. We have the most common antibiotics that we consume mostly are the broad spectrum. But we're aware that there exist narrow spectrum antibiotics, but due to the same reason and the same web that you showed, it's not coming up to the market. So sir, we can't say that there is no need of narrow spectrum antibiotics because antibiotic resistance is because of broad spectrum only. So why is the reason that we're not letting it come out? Because it's been 30 years, 40 years now.
I have no
They
idea.
have
See,
printed enough money
I
on it.
really, I really don't know why it's not coming. See, I have not done much research on that, but are those safe? Are those cost-wise comparable? All those factors will be there, and then are there chances of developing more antibiotic resistance with those?
So it's lesser because in the
Because
broad
they are,
spectrum,
yeah,
untargeted microbes are
also
entering
growing.
it.
Yes,
That's
they are
why
getting
we
used to.
are prescribed to eat have
Yes.
probiotics and prebiotics along with antibiotics.
Yes, yes. And maybe lot of time people knowing what infection is there is difficult. So maybe broad spectrum is a safer antibiotic to use
Cover everything.
to cover everything. So you are not just targeting one or two bacteria. So we don't know, is it regulatory? Is it research? Is it the companies involved? We don't know where it's getting blocked. Because any clinical trial can be very, very expensive.
That's true.
Is it happening? Maybe it happened. Did it fail for some reason? And now is somebody not ready to go for another clinical trial? I'm sure if we search, there will be information on internet. We can definitely find something. but I don't know off the top of my head those answers.
And so, one last question on the hospital-acquired infections. How do the hospital advocate that this infection was not acquired in the hospital, whereas the patient says, "I got it here when I came"?
Okay, you ask very difficult questions. In the final exam will be difficult for you. So honestly, hospital-acquired infection is a very, I'll say, controversial topic, right? Because if the numbers are so high in countries like US, imagine how high these numbers are in developing countries, right? And if you go to hospitals that are not private, hygiene is not good, right? Patients are poor and uneducated. Even if somebody from their family is getting sicker or dying, are they given proper explanation or not? I don't know. Can you even blame hospital? See, we are educated people, but even if something happens to somebody, can you pinpoint, if let's say somebody is getting treatment for cancer and they pass away, is it because of their immunity is compromised? That's why they got infection easily. And now was that infection due to hospital acquired infection or because of their cancer? How can you hold anybody accountable? So I think it's a very difficult question to prove who's at fault. That's what at least I feel. And now maybe there are ways to say, maybe because somebody has a vascular catheter, there is a port. Nurses and doctors are accessing that port every day. Is it necessarily their fault? I mean, is it the fault of the hospital? I don't know. Even if somebody was doing that, accessing that port at home, maybe infection could have still happened. Hospital is more prone because of all the patients who are sick. And is it because of negligence of some staff member who didn't clean the port before with the alcohol before using it? How can you blame anybody now that what happened and why the infection happened? And I'm sure in hospitals maybe there are protocols to figure out that infection happened, what are the reasons. But I'm also sure there are so many times where maybe hospitals are not getting blamed because nobody can pinpoint. And I'm not saying their hospitals are wrong also. Maybe it's not their fault also. So it's just a very difficult question. So that's why my answer to that is, we don't need to blame hospital or patient. Why not make devices that are antimicrobial so that the chances are reduced by 50% of getting infection? That might be a better way to handle it. But I'm sure these numbers are very high, people getting infected, but again, people are so immune compromised or not even. See, when I come to India, I'm so careful with my water drinking and what I'm eating because the immunity is now not, I don't know how easily I can get sick, right? So now, but it's a good question, but I don't know we can pinpoint whose fault is it.